My topic for this first policy analysis was lowering the use of hospital emergency departments for non-emergent care. The development and use of the hospital emergency department was a welcome addition to the public health system, as the ED provides patients with access to immediate treatment for acute and emergent health issues day and night. Unfortunately, a commonly reoccurring theme that is being seen in this setting is the use of the hospital ED as an open access primary care clinic. This has led to an overcrowding for both the emergency department but also for hospitals as ED admissions increase. The goal of this PowerPoint is to analyze why the ED is being used in this manner and to identify the challenges and strategies for addressing the use of hospital EDs for non-emergent care. So the first thing we need to ask is, why do patients go to the emergency department for non-urgent care? In a study by Bresser et al., they found that 68% of the patients were self-referred, 17% were referred by their primary care provider, 8.5% were referred by a specialist, and 7% were admitted after an emergency phone call, such as dialing 911. Bresser also identified 6 cognitive mindsets that patients have when going to the ED. 1. Patients truly believe that the ED was the correct place to address their acute healthcare problem. 2. The accessibility of the ED. 3. Patients are already being treated by a specific specialist from the same hospital. 4. Patients go to the ED due to the stress of their health problem. 5. They have confidence in the care they would receive at that specific hospital. And 6. They go to the ED due to financial concerns. Research by Shaw et al. Identified 2 main subgroups of emergency department patient types. The first subgroup is patients with knowledge of alternative primary care options, and the second subgroup is patients with no knowledge of alternative primary care options. So for patients with knowledge of alternative primary care options, they may still decide to go to the ED because they've been instructed by a medical professional, they've experienced access barriers to primary care, they've experienced racial issues with their local primary care office, they have transportation or location barriers, or the cost of care of primary care offices is too expensive. And for patients with no knowledge of alternative primary care options, the key reason they may still go to the ED is a lack of education. This patient type is ideal to be targeted by interventions to increase education of the emergency department and when one should go to the emergency department. Research by Chang et al. Found that there was an impact of neighborhood conditions on pediatric non-emergent ED utilization. They found that significantly higher rates of recurrent ED use was present for children living in neighborhoods that were not cohesive, not safe, and had physical detractors. Rundown housing and vandalism was most strongly associated with recurrent ED use. Negative attributes of a child's environment could be reduced by implementing targeted interventions designed to reduce disparities in non-emergent pediatric ED utilization. One key aspect of lowering the use of hospital emergency departments for non-emergent care is that we have to analyze the impact of COVID-19 on the utilization of the emergency department. Research has found that shelter-in-place orders resulted in a 39.6% decrease in ED encounters, and of that percentage, 52.1% were non-emergent patients. Based on this data, we can conclude that many patients with non-emergent conditions can be treated in appropriate care settings such as primary care or urgent treatment centers. These findings indicate that teaching patients how to correctly decide the appropriate care setting for their condition could greatly reduce the use of the ED for non-emergent care in the aftermath of COVID-19. So, how can interventions be used to lower non-emergent emergency department use? Educational programs and the 211 helpline were found to be the most successful in lowering non-emergent ED use. For educational programs, research by Adesara et al. Evaluated the use of a primary care office-based patient education program as a valid method of decreasing non-emergent encounters at the ED. The educational program utilized posters in the primary care clinic waiting rooms and mailed follow-up letters after non-emergent ED visits. They found a statistically significant decrease in non-emergent ED utilization for patients that received the educational intervention. This intervention could also be adapted to telehealth primary care visits, which have become increasingly popular due to the pandemic. For example, after patients check in for their appointment online, they could be placed in a virtual waiting room that displays educational information. Additionally, telehealth visits require the patient to have an active email address, which could then be used to send virtual follow-up emails to patients that are discharged from the ED. The 211 helpline is a free telephone-based information and referral service in the U.S. A study by Garg et al. Identified the helpline as an assistance for a variety of services ranging from medical help to the food pantry to help paying bills. They found that the data provided from the 211 helpline could be used to develop interventions that target neighborhoods that have a high risk of preventable ED use occurrences. Another intervention that is becoming increasingly popular is social emergency medicine. What is this? It is applying knowledge about social determinants of health to the ED bedside and developing effective, systematic interventions that reach out into the community. This is important because just as health diagnostics and medications are an integral part of medicine, so is the environment, social structures, and policies surrounding specific populations. Examples of social emergency medicine in the U.S. consist of the Housing First program, which is a partnership between the Centers for Medicare and Medicaid Services and New York City hospitals. This partnership provides housing for homeless patients at high risk for medical complications, and these patients are identified in the ED. Another example is the Boston Medical Center's Violence Intervention Advocacy Program, which is an ED-based program that targets the physical, emotional, and social needs of violently injured youth that come into the ED as patients. And finally, the SBIRT, which is the Screening, Brief Intervention, and Referral to Treatment Program for Substance Use and Behavioral Intervention of the ED. And by incorporating the SBIRT, research found that the coordinated care of the ED, positive clinical and cost-effective benefits were associated with substance use and behavioral disorder patients. Implementation of social emergency medicine will require integration of the study of social determinants of health with medical education and training, as well as education on collaboration among community groups. To address the social determinants of health, the focus of emergency medicine must shift from centering on the single patient to the population level. While some may argue that the present burden of increased ED volumes and overcrowding already interferes with the primary goal of providing acute and emergent medical care, and that tasking the ED with the adoption of social emergency medicine mentality will completely derail them from accomplishing their goal. However, patients that do not receive adequate care are more likely to return to the ED. Ignoring the effects of social determinants on health solely because changes in budgetary resources will be required is the equivalent to ignoring the role of genetics on health simply because reliable methods to control gene expression have yet to be developed. Basically, it's something we have to work towards and strive for. We have to put the research and the effort into it. And these are my references. Thank you all for listening.